I don't know if they changed the software license that I have with this program or what, or maybe I have to pay more money to get a better one. But it only lets me record 50-minute intervals. So if I stop it, because like the supplements one, it's only 50 minutes. I didn't realize it stopped recording. So I might have to stop. I'll try and keep an eye out on it, but it shouldn't take me 50 minutes to get through this, so we should be good. Okay, anyway, anti-epileptics. So talking about epilepsy, epilepsy is a pretty common disease, 50 million people worldwide. As far as chronic diseases go, it's something you're going to see in young people with onset, and up to older people too can have onset too. You can really see it within any stage of life. So it's kind of an interesting disease within that aspect. Treatment response to current medications we have is about 70%, but about 50% of patients will need more than one drug. So the treatment response for 70% isn't great. I'd like it higher than that. And a lot of people will end up with significant polypharmacy due to anti-epileptic drug use, and that's not necessarily a bad thing, but sometimes you just have to give a lot of different drugs to manage this disease appropriately. But on the flip side of that, 50% of these patients will respond well to monotherapy, so that's a good thing too. I don't think this is a big deal in the U.S., at least not that I've experienced, but there are some cultural stigmas around epilepsy. And if you work with certain cultural groups, they may have a certain stigma towards it. It's kind of like, I would say in the U.S., we still have a stigma towards a lot of mental illnesses. I think that might be the case in some countries or some cultures with epilepsy. So 10% of people worldwide will have a seizure at some point during their life, but epilepsy is actually defined as 2 or more unprovoked seizures. So for example, if you have a kid who has 2 febrile seizures, that's not epilepsy, that's febrile seizures. Or if you have a brain tumor and you're having seizures because of the way the tumor is interacting with different brain pathways, that can be, of course, treated with anti-epileptic drugs or attempted to treat that way, but it's still not technically epilepsy. So epilepsy itself is idiopathic, and you have genetics, perinatal issues, trauma, stroke, infections, and cancer can all predispose people to being epileptic. Highest incidence we see are very young patients with early onset and very old patients being at risk too. Okay. Seizures. So a seizure has a couple different types, and I kind of said this already. So there's provoked seizures, which could be something going on to cause it. So maybe there's a drug withdrawal, like you're a chronic alcohol abuser, and you stop drinking alcohol. That's a drug withdrawal seizure. Epileptic seizures are some sort of hyper-synchronization of your neuronal networks that is specifically associated with epilepsy. So when they do EEG monitoring, they're going to see different waveforms of epileptic-type seizures than they will with other types of seizures. Psychogenic non-epileptic seizures, I'm not going to talk about these a lot other than just to mention them briefly. If you work in mental health or emergency medicine, you're going to see this quite a bit. What it is, they also call them pseudo-seizures, and physically they kind of resemble epileptic seizures, but basically it's a physical manifestation of some sort of underlying psychiatric illness. So somebody's actually having a pseudo-seizure, you have them on EEG monitoring, you shouldn't actually see any waveform differences. So it's kind of an interesting disease state that manifests, and a lot of times these patients might end up going down the treatment road of getting epileptic workups, but it's really important if you have a new seizure onset, really important to get a mental health history on the patient as well. Oftentimes, like we have a few patients that are sort of unfortunately frequent flyers who come into our ER a lot with pseudo seizures because they start to have what looks like a big tonic-clonic seizure in a public place. And so somebody rightfully calls them emergency services. They come in, they take them to the ER, and kind of go through the same loop over and over again, even though they don't actually have epilepsy. And there's not much you can do for them other than maybe calm them down with like some benzodiazepines or something. All right, EEGs are going to show different monitoring. I'm not going to go into the details on this because, to be honest, I don't understand it and I'm not trained in that. All right, so classifications of seizures. This comes into play when we talk about the drugs. So there are basically 2 categories of drugs we're going to talk about, broad spectrum and narrow spectrum. So broad spectrum drugs can really work for almost any type of seizure, whether it's partial or generalized. And then narrow spectrum work really only for partial. So there's not really any drugs out there that just work on generalized and wouldn't work for partial as well. So that's kind of the important crossover. Broad spectrum, just think about it, any type of seizure. There are a couple caveats that I'll point out, but that's basically the gist of it. So when we talk about generalized is multiple areas of the brain involved, whereas partial or focal is you can pinpoint it to one side of the brain or one specific location within the brain. And usually partial seizures are going to be less pronounced as far as how they present themselves in a person's physical manifestation of the disease. So partial seizure could be anything from just a sudden loss of unconsciousness, whereas what we think of generalized seizures like a full tonic-clonic seizure of having jerky, rapid movements. So that's sort of the difference. But you can definitely have some of those movement type things with a partial too. It's just usually not as pronounced as a generalized. And just in case you're curious about some general stats on what the more common types are, you can see that complex partial, generalized, tonic-clonic, and other generalized make up a very big chunk of what we're treating. Absent seizures are a little bit different. They're a little more rare, and they have a bit of a different treatment pathway as well. I don't care that you know this for my exam, but it's just on here in case you're interested in some of the kind of classifications of epileptic seizures and the phases somebody would go through during a tonic-clonic seizure. So usually people don't have much of an aura, but you get the tonic phase, clonic phase, and post-ictal phase. Post-ictal phase is really important from a patient education standpoint, I think, is making sure people know how to deal with a post-ictal patient or how to recognize a post-ictal phase. Because normally, I used to work with a pharmacy technician who would get partial seizures while she was working. She wasn't medicated, and she should have been, and there's a whole other story with that. But anyway, she would just kind of collapse on the counter, and she'd look like she was almost like resting her head. And then we'd notice she had a seizure because she'd start getting argumentative with customers because she wouldn't understand what they're saying, and she'd just kind of say ha or hello over and over again, and she's post-ictal. So you could imagine it's especially problematic if somebody's driving a car or something like that. Even any type of seizure, of course, would be problematic with that. So there's lots of different social issues to consider too, which I'm not really going to get into, but I think it's kind of interesting to think about. Okay, so drugs. There's a number of different AEDs on the market. Like I said, these two next two slides don't have everyone on there, but they have most of the current ones we use, and it shows you the different pathways that they're going to take. So pretty much an AED is going to work on two different general pathways within the brain. And this would be the excitatory synapse. So this is going to be responsible for generating those hyper-excitatory responses that's going to cause the seizure actually happening. In this case, there's a number of different pathways you can do to actually decrease this excitatory response or the ability to your brain to overreact to excitatory stimuli. So you can see a lot of drugs up here, like phenytoin, carbamazepine, etc. They all work on sodium channels. That's a very common pathway that a lot of anti-epileptic drugs fall into. They're sodium channel blockers to basically prevent overall depolarization in some of these nerve cells, decreasing the hyperexcitatory response. And you can see there's a number of other ones that might work downstream. So like levetiracetam or Keppra works intracellularly on a different mechanism. Topiramate works further downstream, but still blocks some of these neurotransmitters. Potassium's, in this case, is what's being used as a neurotransmitter getting released and activating other sodium channels. Felbamate works on things called NMDA receptors. NMDA receptors are associated with the, if you have something that blocks NMDA receptors, they call it a dissociative response. So what it is they're all over the brain and the central nervous system, but it has to do with how the central nervous system communicates with the exterior periphery. So how like your body is telling your brain's telling your body what to do. And so sometimes people with these NMDA receptors, when you block them, like a drug like ketamine, which we're going to talk about a little bit more with psych, is a drug that actually works in this area too. And felbamate works a little bit like this too, and it actually blocks some of that transmission between those two systems. It's kind of an interesting area of medicine that I think is really being explored a lot now within pain management and mental health. Felbamate, ketamine, probably the only two drugs we have that work in that pathway substantially right now, but I think it's going to be a growing thing we see over time. And then you have the other side of the coin, which is basically augmenting your natural inhibitory synaptical responses. So this is going to be using primarily, there's a couple drugs that are used for partial onset seizures, so like vigabatrin and tiagabine, really unusual drugs that I'm not going to test you on. But drugs like benzodiazepines are what we'd give. These are like lorazepam, diazepam, Ativan, Valium. They're what we're going to give for acute seizures. And I'm not going to talk about status epilepticus. We'll talk about that during emergency medicine in the summer specifically. But you would give a benzo to do that. And benzodiazepines theoretically would work if you gave them chronically for suppressing seizures. However, they're addictive. People build tolerance to them, and if you withdraw from them, you can get a seizure very quickly. So there's a lot of dangers to using them, so we try not to use them chronically, but they are the gold standard for an acute epileptic episode, so we would give them. And what they're doing is they're potentiating the body's ability to maximize its use of GABA, which is gamma-aminobutyric acid, which is just a mediator of this whole inhibitory process in the brain. So it's going to very quickly shut down all those excitatory processes that's going on, cause a lot of inhibition. which is exactly what you want in a seizure situation. However, getting somebody to function on that long-term type of a mechanism is very difficult because of its also sedative abilities and addictive potential as well. A couple other drugs work here too. You can see there's some mixed mechanisms. So if you look at topiramate, you can see, I think topiramate's over here again. Felbamate works as a sodium channel. It also works here. So there's some mixed mechanism there too, making some of those drugs possibly more utilized in different situations. Now, as far as mechanism goes, you can look at it as a, well, should I mix and match? Like, should I not use more than one sodium channel blocker? And there isn't really a strategy for that. So when it comes to other medicine, it's almost very specific. Okay, we take specific mechanisms, function in certain areas, and we mix and match to get synergistic approach. And you can certainly do that, but you can combine sodium channel blockers without issue. So you'll see that actually a lot in epileptic care, is that they're combining medications. And if you look at how they work, very similar mechanisms. So sometimes it doesn't necessarily make sense, but it does work in practice. And now on to some of the drugs. So I'm going to go through the more broad spectrum, more common medications. And I think I've got 5 or 6 slides dedicated to probably the most common anti-epileptic drugs that are used out there. And we'll talk about some of the more unusual ones and maybe a couple little pearls here and there. But I definitely want you to know the ones that have slides dedicated to them. And I've kind of got them in order of, at least from my experience working with our epilepsy group and what I see people take and what we use and what we start people on regularly in the hospital. These are the most popular ones and probably the way I would approach a patient. However, that's going to really vary, and I'll give you a lot of caveats to that because I don't want you to think that this is like absolute law, because it's not. Epilepsy is not a specific algorithm. Like, you don't always start with Keppra, but a lot of times we do at our hospital. It's just how we practice with our epilepsy group. Okay, so Keppra. Keppra is a broad spectrum anti-epileptic drug. It's a really interesting drug because it wasn't, and I don't think it actually ever got approval for generalized seizures. Maybe it has finally now, but for a while it didn't. But people just started using it because they found that it was good. And it actually works quite well for monotherapy, even though you won't ever read, like if you go to UpToDate and look at treatment for epileptic patient and starting medications, they don't recommend Keppra. However, we do Keppra almost exclusively for new patients. So why do we like Keppra? There's no drug interactions. Virtually every other anti-epileptic drug interacts with other anti-epileptic drugs. I spent a day with an epilepsy-specific pharmacist, and she has this big chart that's like got 20 boxes on it. It says, okay, if you start somebody on valproic acid and they're also on lamotrigine, you have to decrease the valproic acid dose by 30%. And there's all these different mix and matches that she put together based on enzymatic interactions. Keppra doesn't have any of these. It's one of the nice ones where you can add it on to really any existing regimen without getting interference. And when you start somebody on it, you don't have to worry about what else they're taking from a drug interaction point of view. So there's a huge benefit there. Side effects are pretty minimal. I've got probably the biggest one listed down there, which we'll talk about in a second. And also it comes PO and IV. So the nice thing about that is if you have somebody who's non-compliant with their anti-epileptic drug and they show up in your hospital with a seizure, you can give them a big loading dose Keppra IV. You're getting 100% bioavailability immediately, and you can get their levels back up to normal very quickly, which is a huge advantage. We have other drugs that do that too, but this is one of the ones that we use quite a bit. You can also use IV Keppra to actually stop a seizure from progressing. So during status epilepticus, you can give somebody IV Keppra. And that's usually our second choice once we've given somebody a benzodiazepine. So we love Keppra at Abbott. I think a lot of people like Keppra just because of some of these things. So what cons does it have? Twice daily dose. There is an extended release once daily formulation. It's more expensive. Renally eliminated. So you do have to adjust it for renal dysfunction. Behavioral side effects would be the biggest general things people are going to experience, and they can be up to 10% of patients will experience some form of these. So, and they can be really all over the place, anything from anger and aggression to like irritability and depression. There is some thought that if you have underlying mental illness, it could exacerbate that. However, it's not a contraindication to starting Keppra. So if you have somebody who's already depressed, if they're being managed well, I would say you could go ahead and start Keppra. If they're in the middle of a bipolar episode or something like that, probably not. So use common sense with that. But overall, it's not a contraindication, just a precaution with that. And we do titrate it kind of slowly because it is a little bit sedating at first. But usually once people get used to it, it's not as sedating. Okay, next, lamotrigine or Lamictal, another super common broad spectrum anti-epileptic. Very well tolerated drug. There's one big caveat to this, but you just need to start it appropriately. You have to titrate it up really slow, which I've gotten into the cons section. It's a once daily dose. It's got a 25 to 35 hour half-life. occasionally you see people split up the dose, and I'm not exactly sure why they do that. If they maybe get some of these dose-related side effects, like maybe tremors or dizziness, if they take it all at once, so they split it up for that reason. But you technically don't have to. It's not really adjusted, but there is some caution maybe, so you can get away with it more so in a patient with renal dysfunction. And there is some better evidence, looking at some meta-analysis that support that it's maybe a bit better in pregnancy than any of our other drugs. I'll talk about pregnancy at the end and how we approach that very briefly, but it is more or less the drug of choice in pregnant patients. Slow titration. So usually you're looking at about 2 months to get somebody on lamotrigine up to a dose that's therapeutic for anti-epileptic drug levels. So we use lamotrigine a couple different ways. We use it here, and we also use it significantly in bipolar patients as well, which we'll get to during mental health. The doses are much higher in epilepsy. So the problem with that is if you have somebody who needs to be on an anti-epileptic drug that you want to start working quickly, you just can't get them there safely, quickly. So that's why Keppra is a really popular choice for acute care, because you can give them, even though it's a bit sedating, you can get them up to a healthy dose pretty quickly. With lamotrigine, you just can't do that. You would just be risking Stevens-Johnson syndrome, which of course you don't want to do. You guys talked about SJS a little bit? Okay, good. So most people who have been acceleratedly titrated on lamotrigine are going to probably not get Stevens-Johnson syndrome. It's still going to be quite rare. However, the risk is quite high, and people will get rashes and breakout and stuff like that and get different types of dermatologic reactions. So we do avoid it. It's really important if somebody quits cold turkey on Keppra or lamotrigine, or if they decide stop taking it for whatever reason, and don't start them on their dose. You need to retitrate. Usually after about 3 or 4 days of being off of it, we do a full retitration. There's still a risk, even if they've been on it and tolerated that dose. It's probably theoretical, but we want to err on the safe side, because SJS can kill people, and if nothing else, can lead to a really long hospital admission and a lot of long-term complications. Drug interactions. So there's not really any CYP enzyme inhibition issues with lamotrigine. However, there have been studies looking at different levels in combination with lamotrigine. So valproic acid is the next drug we're going to talk about, another very common one. They've shown that for some reason valproic acid levels get higher when you give it with lamotrigine. It could be due to protein binding. A lot of these drugs bind to albumin and other proteins, so it could be competing for those spots potentially, but we don't know exactly why. We just know that valproic acid dosing tends to be lower when you give it in combination with lamotrigine. And then there's some enzyme inducers, so drugs that induce the CYP system. For some reason, that does seem to affect lamotrigine, even though it doesn't really get metabolized by the CYP system. So maybe there is some CYP interactions there that we just don't understand fully. One really common one that I'll put out there is combination oral contraceptives do increase the metabolism of lamotrigine, so you would have to dose increase somebody on birth control. And then, anyway, besides the rash, very well tolerated medication. Doses drug side effects are quite low, and you can see them listed there. There's some movement type disorders, insomnia, but usually it's very high doses. So normal therapeutic doses, people tolerate this drug quite well. It's a very popular medication for that reason. The biggest issue is just getting it to the point where you have it therapeutic. Valproic acid. So valproic acid is another good broad spectrum one. A lot of people would say that valproic acid is the gold standard when it comes to broad spectrum anti-epileptic drugs. So if you're going to treat somebody for a generalized seizure disorder, this is the drug you should start with. Now, personally, I disagree with that because of the side effects. If I had epilepsy, somebody wanted to start me on valproic acid, I'd politely tell them to prescribe me Keppra instead. And if they disagreed with that, I guess I'd find somebody else to do it. But no, I mean, the side effects aren't great, whereas our other two drugs, they're quite a bit better. So I'm all about treating the patient appropriately, but I also want to take side effects into consideration. So pros to valproic acid. There is an IV form available like Keppra. So you note that lamotrigine does not have an IV form. It's just oral only. And I call levetiracetam Keppra. I'm sorry for using the brand name. This is levetiracetam. It's kind of hard to say, and it's a long word. Keppra is easy. So valproic acid comes in a number of different forms. So you'll see a bunch of different brand names. Depakote's the standard brand name for it, but you'll also see Depakine, Depakon. They all tend to do with the different formulations. For example, Depakon is IV, Depakote is PO, Depakine is the oral liquid. Not that it matters to you guys, but just so you know that that's how they differentiate those different brand names. But valproic acid is a really safe thing to remember. It covers everything. They're all valproic acid. But anyway, there's an IV form available. You don't have to renally adjust. And you do have an extended release product that's dosed once daily that's generic. So all really good things with this medication. It's contraindicated in pregnancy. There's a 1 to 2% chance of spina bifida. If you do have a patient who's stabilized on valproic acid and you don't want to switch them, you would supplement with folic acid heavily to make sure you're not going to get that side effect, but it is still a risk. So generally speaking, this is one of the big ones that is commonly used that we don't like in pregnancy. The rest of them are all thought to be mostly okay. It is an enzyme inhibitor. It's highly protein bound, so you have a lot of drug interactions to consider with valproic acid. Anytime you add something to the valproic acid regimen, with the exception of Keppra, or anytime you're adding valproic acid onto regimen, you'll notice if you look at different drug monographs and how they recommend dosing valproic acid, they'll say if you're on these anti-epileptic drugs already, dose it this way. If you're on these anti-epileptic drugs, dose it this way. So pay close attention. You know, if you go into epilepsy, which I know we have several PAs in our hospital that work with our epilepsy group, so I know it's a viable practice for you guys. But if you decide to go into it, it is something you're going to get really familiar with dosing these things. So I'm not going to test you on this specifically, other than just to know that there's drug interactions to consider. But just know in the future that you would have to take those into consideration. All right, side effect profile. Tremors, alopecia, 25% hair loss with people, both men and women. Thrombocytopenia, weight gain, and blood dyscrasias, irregular menses in women. These are all relatively common. So there's more monitoring involved with this and just more general tolerability side effects. It's not like losing your hair or gaining weight is going to kill you, but it is going to make you really annoyed, and it's going to make you not want to take the drug anymore, which, of course, if you stopped, you could have a seizure. So, again, side effect profiles come into play when you're thinking about adherence and compliance. So that's why valproic acid, to me, takes a little bit of a backseat. Even though it's a very effective, good drug, it's a little bit more problematic. Also, if you have somebody with borderline mental illness, and we do use this for bipolar disorder too, if you take a lot of this, it's pretty nasty and overdose. You can get hepatotoxicity. There is a reversal agent called levocarnitine that we can give, but it can be bad in certain cases. So, monitoring. So we want to monitor liver functions, ammonia levels, depending on that, and CBC. So you want to get a lot of baseline labs and follow up with people as you're changing your titrating doses. All right, topiramate or Topamax is another broad spectrum AED. If you look at evidence for all these AEDs, there's not a lot that says, okay, we know for a fact this drug's the best. Whenever you test it against anything else, there's no real, well, I said valproic acid's kind of the gold standard. It hasn't really been put to the test against every other anti-epileptic drug out there for every specific type of epilepsy. So it's very difficult to do that in a clinical trial, from a clinical trial perspective. When it comes to Topamax, there has been some evidence more so leaning towards saying it's maybe a little bit weaker as far as its efficacy, but it's still a useful agent. So don't take it as, we don't use it, but it is still quite commonly used. Some pros, weight loss. So this may be a con, depending. You, of course, don't want to give this to somebody who is, really underweight already. But if you have a diabetic patient that could stand to lose a few pounds and they also have epilepsy, this might be a good choice for them. Cons, so it's also known, so the brand name's Topamax, people call it Dopamax lovingly. It makes people kind of slow, more or less, depending on what dose you're on. So one of the big things is this sort of just psychomotor slowing. So people just can't process information as fast. It's a pretty well documented side effect with it, which for most people, not going to work out really well for their day-to-day life. So, if you don't have the side effect with your patient, great. But if you do, it's going to be a problem, I think, for adherence. It is renally adjusted. There are a lot of drug interactions to consider with this drug too. Twice daily dosed usually. And side effect profile has a variety of things. So then again, the slow thinking and speech difficulty up to 30% of patient reporting is the big one to remember with Topamax. The rest are all kind of backseat compared to that. Okay, phenytoin. Phenytoin is one of the older drugs. So the four we talked about so far are all kind of newer generation. Phenytoin is an old generation anti-epileptic, but still heavily used today because it's highly effective. It's got a lot of issues with it though. So it does come as an IV form, so that's another good advantage. And this is a drug we can give people for acute epileptic episodes. We can load them up with a phospheniton loading dose. Phospheniton is the IV form. So the IV form is just formulated differently, but it's all dosed in the same. They call it like PE equivalence, which doesn't matter to you guys, but if you ever see that term, phenytoin is, IV phenytoin is essentially just phospheniton dosed in phenytoin equivalent. So you can kind of do a one-to-one conversion that way for dosing them. Cons. So narrow therapeutic index, free versus total level. So this is a really highly protein-bound drug, and the toxicity gets really close to the therapeutic levels that we're looking at, the toxic blood concentrations. So when we're doing testing on phenytoin, we want to make sure they're in a certain range. If somebody is malnourished or maybe has a low albumin level, we want to make sure that we're looking at a free level as well, because that's going to be the active phenytoin that we're seeing. Versus the total level, which includes protein-bound and free drug. Drug interactions. So this is a strong CYP3A4, 2C and 3A variant inducer. So this is one of the few drugs that's relatively common that actually induces enzymes. So this is going to increase metabolism, but it's also metabolized by 2C. So it actually induces its own metabolism, which is kind of interesting. So you might have to increase your dose slowly as you get somebody rolling on phenytoin. Side effect profile. All over the place. So dose-related, high doses, phenytoin toxicity, nystagmus, slurred speech, and ataxia. Normally I don't get into toxicity too much, but in this case it's so close to the therapeutic range that it's worth mentioning how to see a toxic patient on phenytoin. Dizziness, drowsiness, hirsutism, gingival hypertrophy where your gums grow over your teeth. Hypersensitivity to the medication is more common than a standard medication. And hyperglycemia. So there's a number of side effects, kind of a big mixed bag, right? I don't know if I want you to remember a lot of these, other than that I would think that dizziness and drowsiness, some of the nystagmus, slurred speech, toxicity stuff is probably important. Long-term cerebellar atrophy potentially, and it's also teratogenic too. So there's a lot of different issues with phenytoin out there that are problematic. However, if you titrate it well and keep it within its therapeutic range, you can avoid a lot of these side effects. It just comes with understanding how to do the kinetics on it properly, and I'll talk about that in a little bit. All right, carbamazepine and oxcarbazepine I put on the same slide. So their brand names Tegretol and Trileptal. If you work with these drugs, make sure you're saying the right one. It's really easy to mix these two up. They're both broad spectrum. Oxcarbazepine is basically a newer, slightly modified version of carbamazepine. And oxcarbazepine is generally better tolerated when you look at overall side effect profile. So shared side effects. Rash and hyponatremia are two of the more common ones, and drowsiness. So this is a medication that tends to make people a little bit dizzy and drowsy. Tegretol specifically, or carbamazepine specifically, has an agranulocytosis risk. So you do more CBC monitoring, make sure those ANC at baseline isn't too low. And occasionally you're going to want to check the ANC to make sure it doesn't drop below a certain range. It is a CYP inducer as well, so it's similar to phenytoin that it actually induces its own metabolism. But that's really just Tegretol. Oxcarbazepine doesn't have that same effect. So if you're looking for a more drug interaction-friendly medication, oxcarbazepine is going to be preferred. Both medications have pretty short half-lives, so dosed anywhere from 2 to 4 times daily, and they both have extended release formulations for less frequent dosing. So the question is, why would you give one over the other? Well, carbamazepine has been generic for a long time. It's probably the cheaper option. Oxcarbazepine is generic now. It wasn't for a while. Some of the different formulations of it, like the extended release components, might still be brand names. So it's usually going to come down to a cost thing. But oxcarbazepine is generally the better tolerated medication. Both of these medications can actually exacerbate absence seizures. So where all the other ones are pretty much fair game for any type of seizure, that's one of the big caveats to this one's broad spectrum label, is that you wouldn't use it in absence seizures. All right, and a whole bunch of other broad spectrum AEDs. So really the only one I want you to know on this slide is the top one, which is zonisamide or zonegran. Zonegran, I probably should have its own slide for, but I was kind of lazy. Zonegran is a pretty well tolerated monotherapy approved, or not approved monotherapy, but monotherapy studied. So they are using it as a first line monotherapy agent as a broad spectrum AED. So it is getting much more popular. It is falling into place as one of the more first line choices because it's relatively well tolerated. It does have an anorexia side effect, so decreased appetite. It does interact with sulfa allergies, so if somebody's had an allergic reaction to a sulfa antibiotic, they might interact with zonegran. It does cause some psychiatric things like possibly exacerbating depression, but generally one of the better tolerated medications. If we're looking at all these broad spectrum ones we just talked about, carbamazepine, oxcarbazepine, and phenytoin probably being less well tolerated, valproic being maybe in the middle, and the other 4 or so being a bit better, cut above the rest as far as side effects go. And if you work in epilepsy, you're going to see all these drugs used. So I don't mean to blow them off like no one uses them. They're just less common. I don't think it's worth making you memorize every single one. Ethosuximide, I'll just mention, it's only approved for absence seizures, and it's actually first line for that. So it's really one of the only drugs that has a specific type of seizure that it's first line indicated for. But absence is quite rare. You don't see it very commonly. Yeah.
What does that mean?
It's a type of generalized seizure. I don't know, other than that.
We thought maybe you were just like,
no. I don't know if it's like a French, but that's how they say it. They call it absence, and I don't know what. No. It's spelled absence, you're correct. I don't know if it's a French word or what. Yes, absence, yeah. Yeah. I'm not trying to be fancy or pronounce words inappropriately on purpose. Yeah. Unless, every professor I've had who's ever talked about epilepsy is just stuck up and likes pronouncing it that way, but that's how everybody says it, so don't kill the messenger. That's just me. All right. Some other medications just for partial seizures. So these are ones that you wouldn't use for generalized, obviously, but you could consider them as adjunct therapies mostly for partial seizures. And these are mostly newer medications or less commonly used. Lacosamide is probably the most common one. It's actually a controlled substance, so you have to give like special regulations with it, which is annoying. But it does have an IV formulation, which we're always looking for good IV formulation anti-epileptic drugs, mostly for the reason that, well, two reasons, big reasons. You can stop a seizure cold in its feet before it gets rolling if you can give somebody an IV medication quickly. We have lots of good drugs that do that, but you get these patients that have really bad epilepsy, especially kids sometimes. They're really uncontrolled. Like we've had to put, when I was at Children's, I did a rotation there, and I spent some time in their emergency department. They had one kid, they basically had to sedate on propofol, which is an anesthetic, for their seizures, and nothing else would touch them. They tried everything under the sun, which is very unusual. Sometimes you get these cases where you just need something else. So the fact that this comes IV, it might have some promise for more acute care use. However, for now, it's partial seizures, but it's a pretty good drug, and we do see a fair amount of it being used. So I'd say it's out of these grouping on this slide, it's the more commonly used one. All right, so monitoring levels. So you can draw drug levels on pretty much every anti-epileptic drug, specifically the more common ones, especially I should say the more common ones. So you're talking about like Keppra or lamotrigine or valproic acid, for example. All these medications have really wide therapeutic indexes, so we aren't really too concerned about where they are within that. You might talk to people who specialize in this or neurologists who specialize in this and say, well, I want a valproic acid level to be a bit higher than what the average would say to do it. Well, that's fine. That might be anecdotal or based on small studies, and I don't have any problem with that. What I'm saying is the wide therapeutic index doesn't really tell you much when you're doing a drug level. So if you take a drug level on somebody on valproic acid and it comes back normal, it tells you it's normal, and that's really it. What you're using these levels for mostly is to check for adherence. So if it comes back with nothing in it, it's a good sign, right, that they didn't take their medication. So a lot of times when we have people come into our ER seizing with an epilepsy history on anti-epileptic medication, the very first thing they do is draw a Keppra level or whatever it may be that they're on, just to get that baseline to say, okay, is this a problem with their Keppra? Do they need to go up on their dose? Do we need to add adjuncts? Or do we need to tell them to actually take their medication? So those are all, of course, very important questions to ask. Now that's with the newer AEDs with a wider therapeutic index. With older ones, like mostly phenytoin is what I'm getting at here, that can be used to actually check for toxicity and if they're in that therapeutic range. And I think I talked about this way back when in the very beginning of fall. We mentioned kinetics. Phenytoin is one of these weird drugs that has some exponential kinetics to it. So the more phenytoin you take, your blood concentration, usually when you take a drug, you're pretty much got a linear response. So you take a dose, it's going to go up is in a linear fashion in your blood, depending on what the concentration is. With phenytoin, because of its highly protein binding, usually you hit a saturation point, and all of a sudden you get a massive increase in free level, which is going to increase your general level too. So if you take enough phenytoin, like if you already have somebody who's maybe, you check their concentration, it's 19, and maybe they're still having problems with epilepsy, well, should you increase their dose? Well, if you double their dose, you could like quintuple their actual blood concentration and make them quite toxic. So you have to be really careful with increasing phenytoin, especially if they're in that therapeutic range. You can play with it a little bit, but you should very small dose increases, don't like double it. Like with Keppra, something like that, we might hit them with another 500 milligrams, or that might be on 1,500 a day. We might up them to 3,000. So big increases like that, we would not do that with phenytoin. Gabapentin and pregabalin, you'll see on those initial slides the drawings of the synapses I showed you. These aren't really great anti-epileptic drugs. They originally developed for the use in epilepsy. And I think people get the misconception that they are for seizure treatment. And they can be technically used as adjunct therapy for partial seizure conditions. However, they have a ton of use elsewhere. The gabapentin specifically, with neuropathic pain, various pain syndromes, like people with these kind of undefined chronic pain syndromes, they'll try drugs like these to see if it helps. Restless leg syndrome, general anxiety disorder, and a lot of psych conditions are like, well, let's give a little bit of gabapentin here and there. And so gabapentin and pregabalin have seen a ton of use, but because of these indications, not because they're anti-epileptic drugs. However, technically, they fall into the class. Both are pretty well tolerated. We'll touch base on gabapentin and pregabalin briefly when I talk about restless legs. But there's not much to say. They're well tolerated medications. Usually dose-related sedation is the biggest side effect. And pregabalin is actually a controlled substance. When they did clinical trials on it, they found people got some mild euphoria with it, so they slapped a C5 label on it, which is the lowest tier of controlled substances you can have. Like, for example, pseudoephedrine is a C5 drug, technically. Gabapentin, there's been a big debate within the pharmacy and medical world on whether or not it should be a controlled substance, because there are a lot of reports, actually, from what I hear, that people come into community pharmacies and actually kind of have drug-seeking type behavior for their gabapentin. So I wouldn't be surprised to see gabapentin get a controlled 5 on it at some point in the near future. It's been rumored for a year, and I still haven't seen it, but it keeps coming around, so you never know. We'll see. But it's going to create a lot of headaches for a lot of people because there's a ton of people on it. All right, some other newer drugs. I'm not going to test you on the new medications because once a new drug comes into this market, there's just not a lot of space for it right away. It really has to prove itself. It's really expensive. The nice thing about anti-epileptic drugs is a lot of our, quote, second-generation ones like levetiracetam, lamotrigine, valproic acid, they've done generic over the last 5-10 years. They're pretty, even though they're kind of expensive, I think, if you compare them to like lisinopril, they're much cheaper than they used to be. So affordability is an issue for a lot of patients, and specifically when you're introducing new expensive brand name products, it's going to be difficult to justify it. Now, where these are going to fit in are really complicated patients that have tried everything, you need to try something else. And I'm not really even going to talk about them. The only one I've actually seen occasionally here and there is brivaracetam, which is kind of like a Keppra analog. It's supposed to be about 10 times more potent than Keppra in its anti-epileptic ability. So I think if I was going to be a betting person, I'd put my money on that horse as being the more popular one out of these ones. I occasionally see clobazam used, which is brand name Onfi. It's a very unusual benzodiazepine. It's a long-acting, subtly affecting benzodiazepine, so it doesn't have quite as much sedation, not as much addiction potential. It is still a controlled substance, but it's essentially like a benzodiazepine. But if somebody needs chronic benzos, so if somebody's tried pretty much everything else, they might put them on clobazam. Again, these medications are mostly for people who have tried a lot of other things and aren't having any success. All right, for generalized treatment, monotherapy is your choice initially. You aren't ever going to really start somebody on 2 drugs. There's no real indication for doing that. So looking at broad spectrum plus good side effect profile. So again, I say lamotrigine or levetiracetam. For the majority of patients, one of those 2 should work for them. Maybe stick away from levetiracetam if you're going to have maybe mental health issues. Lamotrigine is going to be problematic if you need fast action now. So the thing about epilepsy to think about is that if somebody has one isolated seizure or 2 kind of isolated seizures over a longer period of time, but somebody's having regular seizures that kind of come on suddenly, you might not want to use lamotrigine just because it takes such a long time to get. Or you can bridge people too. So you could start somebody in the hospital on levetiracetam, get them up to therapeutic level, and maybe switch them off to lamotrigine over time. So you can use faster acting AEDs as a bridge to therapy if you want somebody on lamotrigine overall. But divalproex, topiramate, and zonisamide are all indicated and useful as first-line agents. The reason why I don't include phenytoin or carbamazepine is just because they're more toxic, and our other drugs work pretty much just as well as them. So I don't see a great reason to go to those as a first-line agent. But if you fully titrate one of these and it's not effective, you're basically going going to either A, cross taper it off and try a different AED. So cross tapering is starting a drug at the same time you're decreasing the dose of the other. So basically you're increasing one slowly. So let's say you start somebody on levetiracetam, it's not working at all, not doing anything for them. You want to try lamotrigine. So you're going to slowly taper them off the levetiracetam. You don't usually like to stop anybody cold turkey, especially on anti-epileptic drugs. It's just dangerous. Even if they aren't getting good effect, probably not a good idea. So lamotrigine takes a while to titrate. So you want to taper that levetiracetam as you're titrating up that lamotrigine. Or maybe they're getting some effect from the levetiracetam. They're tolerating it okay. They're at a decent dose. So you want to titrate up and add that lamotrigine. That's perfectly fine to do. It's just really going to depend on the clinical situation. You can have patients on 3-4 anti-epileptic drugs. There's no necessary rhyme or reason to it, but usually you're going to be sticking to these popular ones. So within these, 5 I have listed up here, plus these 2 down here. Those 7 are going to be your core for most seizure disorders that are going to be the most potent, most common medications you're going to see. The rest of the adjuncts we talked about, they fit in here and there, but they just aren't as well used or as popular. If somebody has been 2 to 4 years on medication, they're seizure-free, there actually is some evidence that you can stop their anti-epileptic drug. You want to slowly taper them off, but you really want to consider the risk versus benefit. Was it a couple isolated incidents, or again, was it a lot of seizures, really long-lasting seizures? It's very difficult to get under control in the first place. Of course, it's going to take some clinical judgment there, and a lot of patients might say, I'm not comfortable going off this, and that's fine too. But if somebody is really adamant and wants to try it, there is evidence to support that people can get off an anti-epileptic drug and actually not have recurring seizures once it happens. So it's possible. Partial is very similar. You're going to use very similar drugs. Carbamazepine I put up as a top tier. It's got a little bit more evidence in partial seizures for efficacy, but again, when we're looking at these as a big group of broad spectrums, they're all kind of the same, more or less. And again, you're just going to use the same general strategy. There's not a whole lot of difference with partial. You're still going to use the same drugs. They're all pretty much studied. Like levetiracetam and lamotrigine got approved for partial seizure use. That's where their bread and butter is. Then they moved into generalized seizures. Yeah.
Did you say that lacosamide is the partial only one you want us to?
Yeah, that's a good one to know. Yeah. Yeah, from that slide, that's the only one I would know. Lacosamide or Vimpat. Okay, and then these fancy absent seizures. It's pretty much just a type of generalized. It's usually a pediatric-specific generalized seizure, and ethosuximide is going to come into play as your first line here. Otherwise, you treat them very similarly, with the exception of not using any of these drugs because they can aggravate symptoms. So carbamazepine is kind of the hallmark poster child for this, but apparently there's a bunch of other ones too. So anyway, I'm not going to ask you questions about absent seizures, so don't worry about it. You can ignore that slide. It's just there for your reference. All right, special populations. Pregnant patients have, kind of an interesting catch-22 going on because there's a lot of data that shows that uncontrolled epilepsy during pregnancy is really detrimental to the developing fetus. We know that for sure. And the question is, are our drugs safe? So a lot of patients just have been taking anti-epileptic drugs for decades because you don't want to go off of them. It's too dangerous. So a lot of this is based on review, retrospective analysis, looking at large pools of pregnant patients who were exposed to anti-epileptic drugs and how it affected the developing fetus. The moral of the story here is that new drugs are better and old drugs aren't, and there's a couple of reasons why that is likely. So for the most part, they think that older drugs like phenytoin have a much narrower therapeutic index. So there's a much higher likelihood of getting toxic, higher risk of side effects, which A, could affect the developing fetus adversely, but B, could decrease adherence and put the patient at risk for noncompliance and therefore increase epileptic episodes, which can cause detrimental effects. The newer drugs have the wider therapeutic index, are better tolerated. People are more likely to stay on them, and they're more likely to control their epilepsy better. So from that standpoint, that's basically what we look at. The big risk is that valproic, which is such a popular drug, such a highly efficacious drug, that you're going to come into the issue of women of childbearing age on it, well controlled. What do you do with it? The general consensus is that you don't necessarily have to do anything. You want to supplement with folic acid. However, if there's an option or you have time to transition them off, like if they're like, I want to get pregnant in the next couple of years, can we try to transition into something else? Maybe trial a different drug. But don't do it at the expense of sacrificing somebody's therapeutic management. If they took them multiple trials to get to that point, I would leave them there and probably risk it. Again, it's a low risk. It's not a risk that a lot of people are comfortable with, but at the same time, a seizure during a pregnancy could result in an aborted fetus. So we don't want that. So it's a bit, again, a catch-22 there. But for the most part, we keep it to the new drugs, and we're usually okay with those 4. These 4 were specifically looked at in a big retrospective analysis in Europe, and they showed that they were pretty much the same amount of birth defects as the placebo group who weren't exposed to drugs. So they're all looking to be pretty good. Keppra has the least amount of evidence behind it, but it's thought to be relatively safe, I'll say that. Children, pretty much all these drugs are used and or approved in children, so it's really just depending on what they're going to respond to. We use all the same ones, but dosing and kinetics, of course, vary differently with kids. We'll talk about that during PEDS this summer. And Lennox-Gastaut is a really odd, rare childhood seizure disorder with neurodevelopmental issues. Not really any drug that's useful, and I listed a couple of them there. Just a side note, I'm not going to ask you any Lennox-Gastaut questions. All right, and then finally, well, I've got 2 more slides, I guess. So brand versus generic, not a big deal generally. So this came about, this probably isn't as critical to mention anymore, but it came about probably, I don't know, 5, 6 years ago when a lot of these drugs had very recently, like Keppra and lamotrigine, had very recently gone off patent. And you're seeing a lot of patients concerned and a lot of providers concerned. The generic manufacturers they're giving, the generic versions they're giving their patients weren't up to snuff compared to the brand name, depending on the variants. So again, you have 80 to 125% possible variants to be within spec. In most pharmaceutical companies, generic ones that are good are targeting a much tighter range for in-house metrics. However, technically, you could give somebody 1,000 milligrams of Keppra, and they might only be getting 800. So that's the big issue here. I think that if you can keep somebody on the same brand, it's probably going to be consistent that way. However, I think they were seeing a lot of issues when people were all of a sudden switching from the brand name products to all these different generic manufacturers. They were seeing some case reports come up here and there about generic problems with these. There's actually some legislation introduced in the Minnesota House when I was in school to make it so that AEDs were exempt from the automatic generic substitution laws we have in place, so that you'd actually have to prescribe. So if somebody prescribed Keppra, I have to prescribe Keppra. I can't prescribe a generic levetiracetam. Fortunately, that didn't, in my opinion, that didn't pass. That's a big cost savings, I think. So, and now again, I think a lot of this has died down, but this is one of the areas that I still think there's a lot of uproar about brand versus generic products, and you might see patients on brand lamotrigine or levetiracetam, and they've been on it for years, and they don't want to switch, and their pharmacy orders it specifically for them. They pay the extra premium, whatever. If they want to do that, that's their choice if they can afford that, but a lot of patients can't. So generics are usually just fine. And just a fun slide, if you think this is fun, probably not. But agents reported to induce seizures. So if you're thinking about drugs you use, and if you have a patient who goes into a seizure during a procedure or something like that, what's more likely? Some of the big ones I like to remind people of are the beta-lactam antibiotics. Once these accumulate in somebody's bloodstream, specifically with renal dysfunction, that puts people at risk for seizures. It's one of their biggest side effects. Analgesics, we don't see a lot of them. Fentanyl, I don't know if I've ever heard of that, to be honest, in actual practice. We give tons of fentanyl, so I don't think it's a big deal. Antidepressants, some of these are mostly in overdose situations where you're going to see seizure activity. You aren't really going to see them in regular people. However, the caveat being is that a lot of these medications, specifically within the antidepressant class, can lower the seizure threshold. So bupropion, we're going to talk about during depression a lot, but that's Wellbutrin. It's a common antidepressant, and it does lower seizure threshold. So if you have somebody who has epilepsy, it can put them at risk. Even if they're well controlled on a medication regimen, it can put them at risk for having a seizure. So there are some things to think about with this, but I'm not going to ask you questions about this slide. I just think it's interesting to have, and you can cross-reference it if you're looking at other topics or other drugs. All right, we'll take a quick break. Let's take 10 minutes, come back at 4:30, and we'll talk about Parkinson's disease. Any questions about that? Sorry.